All of you, first of all, I'm thanking Dr. Venkatesh calling me for this wonderful CME program. As you know, the fracture acetabular is not an emergency procedure because it needs a proper planning. Actually, it is instrumentation and implant-specific surgery, and most important, the availability of a experienced acetabular surgeon. There are related indications for emergency procedure like dislocation not reduced by close means intra-articular fragment, large intra-articular fragment following a close reduction, unstable post-dislocation, progressive or sciatic nerve palsy after a close reduction, and open fracture with arterial injury. In 1972, Lieutenant said that the surgical treatment of acetabular fractures mainly rests on the ability of the surgeon to diagnose the fracture type with the standard X-rays and CT scan, and also to select the proper approach. The same thing by Helfet in 1894. The accurate fracture identification is the utmost important factor in the acetabular surgery. Marvin Tile in 1994 said, the fractures of the acetabular remain enigma to the orthopedic surgeon because difficult accessibility and morphological characteristics of the acetabulum, correct characterization of the fracture type is very difficult to identify, selection of the surgical approach, and usually it is associated with polytrauma patients. The goals of acetabular surgery should be the anatomic reduction with the minimum surgical trauma but without complications. But it is often difficult and technically demanding. As Dr. Pradeep said that the acetabulum is formed by two columns, anterior and posterior columns, by inverted shape, by Y shape as described by Lieutenant. But if you have a 3D concept, it is very easy to understand the anatomy and the characteristics of the acetabulum while doing the fixation also. Planning includes the interpretation and classification of the fracture, that is the most important in the preoperative planning of the fracture acetabulum, selection of proper surgical approach, anatomical fracture reduction, and stable fracture fixation. Suppose if your fracture classification is different, your approach may be different, you may not get a good reduction, anatomic reduction of the fracture acetabulum, and the end result will be very bad. So, interpretation and classification of fracture is the utmost important factor in the fracture acetabulum. General assessment, usually it is associated with the polytrauma patients, but the priority is first goes to the chest injuries, abdomen injury, head injury, and soft tissue problems. Sciatic nerve injury is usually up to 40%, mainly in the posterior column or posterior wall fractures. And if you are planning for a surgery more than 1 week delay, it's always better to give a DVT prophylaxis because DVT is very common in pelvic injuries. The operating room setup, the radiolucent table with the traction is very important for any acetabular surgery. Anesthesia, preferably hypotensive because sometimes it will take a long time. Imaging modalities like a good image intensifier, specific instrumentations, specific implants, and assistant personnel, the knowledgeable person is very good for the surgeon, and lastly, an experienced acetabular surgeon. A good image intensifier and a good technician is very important for the acetabular surgery, otherwise it is frustrating to the surgeon. The position of the patient, that's very important, depends upon the approach. If you are doing the anterior approach like ilioinguinal or modified stoppas, you can put in the patient in supine position. And lateral position for the posterior cochlear angle back. Floppy lateral position is using when we are planning for a dual approach simultaneously posterior and anterior. And some surgeons prefer to put on prone position while doing the posterior approaches. I was already said that there are special instruments and implants are available. Usually we are using 3.5 mm low profile plate and screws. The timing of reduction and dislocation. Usually in acetabulum usually present with the fracture dislocation. There is no much difference in the rate of AVN in the patient who are their hips reduced within 6 hours, 7 to 24 hours. But as a general rule, the dislocation should be reduced as early as possible. And if it is stable, give a simple skin traction. And if it is not stable and unstable, put a skeleton traction to prevent the dislocation again, and also to prevent the rubbing of the articular surface with the fracture site. The timing of the surgery already said by Dr. Vivek. The Lieutenant and Jude said that beyond 2 weeks, the anatomic reduction drops from 75 to 62%, but ideally within 2 to 5 days or within a 1 week time. And it is all depend upon the stabilization associated injuries like visceral, skeletal, or soft tissue problems. What would be the ideal approach? The ideal approach should give the anatomic reduction, stabilization of the fractures, and with the least morbidity. Most of the acetabular fractures can be managed with a single or more limited anterior posterior approaches. This is described by Letournel, Mayo, Helfet, and Sagi. Which approach you will select? The most important factor in selection of the approach is the fracture pattern. Other conditions like local soft tissue conditions also very important. Suppose there is a moral level lesions and there is a soft tissue problem in the posterior, better to go for anteriorly. Associated major systemic injuries, just like a laparotomy or a cystostomy or any other colostomy, if possible, you go posterior approach. And the time delay for, if your surgery is delayed after 3 or 4 weeks, you better to go for a extensile approaches for getting the reduction. It's already described that optimal approach, but there is no confusion in selecting the approaches. If it is in a posterior column or posterior wall fracture, you go posteriorly. If it is anterior column or anterior wall fractures, you can select anterior approach. In both column fractures, better to have is first approach should be the anterior approach, and if that is associated with the posterior wall fractures, you can go for a dual approach. But there is a confusion comes in transverse or T-type fractures, whether we go anteriorly or posteriorly. It is entirely depends upon the direction of the rotation and displacement of the fracture. If it is displacement and combination is more than posteriorly, you go for posteriorly or you go for anteriorly. The column with the greatest involvement, if it is anterior column is more involved, you go anteriorly. The height of the fracture related to the femoral head, obliquity of the transverse fracture, that means if the fracture is coming from anterior to posterior, better to go for anterior. Or fracture obliquity from posterior to anterior, you go posteriorly. That easy for the reduction. And presence of impaction and wall fragment, if there is anterior column fracture with the posterior impaction, so we better to go for a posterior approach. So when you do dual approach, usually transstructure fractures are very difficult to reduce to get an anatomic reduction. Such cases, I think preferably to go for a dual approach, or it is associated with a symphysis pubis disruption or a condylar pubic fracture, or extended posterior wall combination. So once you decided, says we are going for a dual approach, which approach will you do first? I think in my personal opinion is, if you are planning for a dual approach, better to go for anterior column first, anterior approach, because anterior column we can fix the anterior column without putting any screw in the posterior column. But the posterior column we cannot fix with the posterior column without any screw in the anterior column. So later if you are doing the first posterior approach, then go anteriorly. Sometimes if you find difficult in reducing the anterior column. So if you are planning for a dual approach, always go for, I think it is better to go for anterior approach first. Colostomy, usually if ask the surgeon to put in the colostomy in the left upper quadrant, so we can safely go for a modified opposite approach. Cystostomy, if you are putting cystostomy tube, always put opposite side of the fracture. I said already that the radiolucent table and fracture with the traction table is very essential for the acetabular surgery. Shank screw in the femoral neck is very useful for reducing the major dislocation of the femoral head. Some of the instruments are very useful in the acetabular. The Farabaugh clamp is one of the beautiful instruments for reducing the fracture acetabulum. Then Weber clamp is equally good instrument for reducing with your fingertip mainly the posterior column and anterior column fractures. Ball spikes, pushers and Shank screw is very important. Shank screw is very useful for to correct the rotation of the posterior column. Pelvic reduction clamps, different clamps are available. So you select which clamp is useful for you. Circlage wires are sometimes very useful in high anterior column fractures, passing through the greater sciatic notch and coming below the anterior spine. We can get a good reduction sometimes. Plate benders, without plate bender, we cannot do the acetabular surgery. It is a very important instrument for the acetabular surgery. And malleable retractors are very useful for, especially you are doing for the anterior approach for retracting the iliac vessels. Neurophysiological monitoring, EMG is the most specific and sensitive, but it is only indicated in delayed surgeries or a malunited acetabular fractures. Then how to avoid the complications? Sciatic nerve is a very important structure coming in the posterior approaches. Knee should be flexed and hip extension to relax the nerve and careful retraction of the sciatic notch. I think better not to use any sciatic retractors in the greater sciatic notch. That may invariably go for a stretching of the nerve. I prefer use my index finger for retracting the sciatic nerve in all posterior approaches. It is very friendly and there is no chance of sciatic nerve injury. Artery injury, hip flexion to relax iliac vessels. So keep a pillow under the knee. We can get a relaxation of the iliac vessels anteriorly. Corona motis should be identified if you are doing for a modified stopper approach. It is usually 5 to 6 centimeters from the symphysis. And careful protection of the supraglottal artery if you are going in the high in the greater sciatic notch, especially in the posterior approach. Avascular necrosis, usually 7.5%. Dislocated hip should be reduced as early as possible. It is already mentioned. And hip capsule should be preserved. If there is only posterior column fracture alone, there is no need to open the capsule to see whether the joint is reduced or not. You see the periphery, you see the outside of the posterior column whether it is reduced or not. And external rotators should be cut 1.5 centimeter from the incision, and Obturator externus and chordatus femoris usually should be preserved to preserve the medial circumflex artery. Heterotopic ossification is very common in male in posterior approaches. It is frequently seen along the gluteus minimus, and a debridement of any necrotic tissue in muscle in that area is very important, and we can prevent to some extent the giving by indomethacin by 75 milligram. Then lastly, how to check the fracture reduction and implant position. That's very important. You have to take AP views, oblique views, iliac oblique, obturator oblique view. You have to see the end-on view and full length of each screw is very important. If the screw is in the joint, it should be there in all views. For example, you can see that first is the AP view, second is a obturator oblique view. We can say that the screw is in the joint, but see the iliac oblique view, all screws in the posterior column. So if there is a screw in the joint, it should be there in all views. See another example that you see that the screws are all, in all x-rays the screws are in the joint. So it means that the screws in the joint. Lastly, computerized tomography is the gold standard. As a beginner in the acetabular surgery, I prefer to advise to take all post-op CT to see whether your implant position, how much is your fracture reduction. If there is any problem, you can improve your in the next case. This conclusion. Proper understanding of the fracture pattern and displacement is the most important in selecting the optimal approach and proper reduction and fixation. The long-term outcome is depends centrally upon the quality of reduction that should be less than 1 mm as described by Mata, and the timing of the surgery ideally within 1 week time. Thank you.